Hello and happy Teach Me Tuesday. My name is Lisa. I'm a NICU nurse and a NICU nurse educator here to bring you another broken down topic for neonatal bedside nurses. Today, we are going to talk about neonatal lab values, especially those that we as bedside nurses are drawing and seeing and adjusting some things that our babies get in regards to what their lab values are. What I wanted to just mention before we dive in here is that if you've been around for a while, you know that I'm an experienced NICU nurse and I've been a NICU nurse educator for 8 years. But what I'm not is a nurse practitioner or a prescribing provider. So that means I've never written TPN. I've never really sat there and been like, okay, the sodium changed to this, let's change from KCL to NaCl or whatever. I can tell you what it's like to be a bedside nurse and interpreting those things, but I'm not going to be able to dive into this topic and say, this is exactly what I would do to adjust your TPN. There are other people out there for you, but we are going to look at these neonatal lab values from a bedside nurse's perspective because we know that laboratory values are essential for us. They're essential for us to track and to trend and to be ready for what to do if our values fall outside of normal, especially if they are severely outside of normal. So that's what I want us to look at today to know why we're monitoring them, what we're looking for, what we should do next, and why it's important to involve our families in this. Because the families are often going to be there when you're drawing these labs and they're going to want to know what they are, what you're looking for, and what they should anticipate. So it's important that we all kind of know that. So, first of all, how are we drawing our labs? There are three primary ways that we obtain blood from babies: arterial, venous, and capillary. Arterial is most likely going to come from your UAC. I have worked on a unit where nurses routinely did arterial draws for blood sampling. If we needed any more than 1 ml of blood, we were not allowed to poke the heel. So we did a lot of art sticks. I loved them. I found them to be efficient and quick, and that they prevented redraws more than capillary sticks. So you often poked once, got your blood, and that's all you needed to do. I don't know about you, but with capillary blood, I do find that you have to do a lot of redraws. However, arterial puncture can be a painful procedure. I've heard from adults that it's one of the most painful things they've had. So, taking those things into consideration, and it can cause abnormalities if not done correctly. So, I've worked on another unit where only certain trained people did it, which I also think is great. I think venous blood is also great. You're probably likely doing that for your blood culture or a large volume of blood that you may need to obtain from the baby. There are units that when you are admitting the baby and you're starting an IV into a vein, they will get your culture and your CBC off of that. I have not worked somewhere that we did that. We always felt like the access was more important and we had other ways of drawing blood, and we didn't want to risk the IV by trying to get blood out of it. Capillary blood is going to be the most common blood that we do draw. Again, I think it's really tricky to get more than 1 cc of 1 ml of blood from a baby. It's doable. Do I think it's our best practice? I don't know. I think it's something you should just kind of take into consideration of should you have guidelines as to at what point you need to change from capillary to venous, especially for certain labs, or as this mentions, if your labs are routinely abnormal from cell lysis, what else we could be doing. We're going to start by talking about electrolytes. We're going to talk about four main electrolytes that we look at: sodium, potassium, chloride, and calcium. So that's what we're going to cover today in regards to electrolytes. So with sodium, the other thing I want to say is that when you look up these ranges, what I have in here is true. These are very typical ranges. I went back to some old information, new information. I got out some textbooks just to kind of see how they all compared. And I found these to be the most common. However, it is imperative that I mention that these are a range for a reason, and we have to take into account everything that's happening with the baby. If you only consider, oh, sodium is this to this, and your baby is a 22-weeker with paper thin skin and with insatiable water loss, it's not going to help you. So keep those things in mind, that these are ranges. So sodium 135 to 145. It's a key role in fluid balance. It's what happens to how we control our osmolality of our babies and our blood and what's going on in the bloodstream. It is huge reflection of our kidney function. I always say you know a lot about your baby with what's going on with their sodium and their pee. So keep those things in mind. When the baby is hyponatremic, so their numbers are low, it's often from fluid overload, excessive diuresis, and hyper is usually from dehydration or excessive sodium intake. Can also be dependent on what's going on with your TPN. Potassium, normalish range, 3.5 to 5.5. Again, you may see higher numbers depending on how you're drawing your labs. This is crucial for muscle contraction and cardiac rhythm. Most of our potassium is intracellular. When your potassium gets too high, it can be really dangerous, especially in regards to some tissue breakdown that may be going on. I've seen really high potassium and the baby's having severe heart rhythm abnormalities. Potassiums over 7 have been equated with death, so things to think about there. If your levels are low, this can come from inadequate intake, things that are going on in your GI system, vomiting, diarrhea, etc. So how do we fix this? Again, I don't write TPN, but I have checked a lot of TPN in my days and listened to a lot of rounds where we discuss what's going on there. So sodium is tricky because a lot of our sodium, as I went back here, is extracellular. So often we need to deal with our fluid and the free water to help change our sodium levels. So if your sodium is low, you're either going to increase the content in your TPN or adjust your total fluids and how much free water the baby is getting if you're trying to correct it. If their levels are high, again, you may need to adjust your fluid status and again, reduce the sodium concentration in your TPN. I would say the hardest part of taking care of ELBW babies, especially those born less than 26 weeks in the first week of life, is electrolyte balance, specifically your sodium, what you're doing with their skin and their insatiable water loss, and all of that plays in a big role of what your sodium and potassium levels are doing. If your potassium is low, you may be adding potassium chloride. I've given a lot of that orally once the baby's off of fluids because it's often pink, so I remember that. And then obviously putting potassium phosphate in your fluids and watching your renal function. If it's high, you may need to give some calcium gluconate to reverse it. Insulin, have you ever given insulin for your high potassiums? I remember the first time I did that and I was like, what are we doing here? But all of that is working together and to help bring that potassium down and what it is binding to in order to excrete it out of the baby. So that's a big part of this sodium and potassium balance that's going on there. While sodium is often extracellular, potassium is often intracellular, and we really have to think about what is going on with our low potassium can have a lot to do with our GI function. So keep those things in mind. Regarding our chloride, typical again, 96 to 111. It works with sodium to maintain the osmolality. If it is low, this can often happen from vomiting and gastric suctioning. So think of those neck babies, or if you have a malrotation or a pre or post-op gastroschisis, something going on where lots of gastric suctioning is happening. High levels are often associated with metabolic acidosis because chloride has an inverse relationship with bicarbonate. So think of how those two things are working together. So if you have a high chloride level, you probably have a low pH. So you're metabolically acidotic. Just things to think about why our blood gases are also so important. Our calcium, so we have total and ionized calcium. It depends if your blood gas machine is running ionized calciums, you may be following those more often. Calcium is the most abundant mineral in the body. It's very common for premature babies to have low calcium when they're born. Did you know that the third trimester is infamous for a calcium and phosphorus push? So if a baby is born before the third trimester, they are missing this push of these essential nutrients. So they are born in depletion. Then there's also just not much coming to them. You know, vanilla TPN is typically, or whatever you want to call it, starter TPN, vanilla TPN, TPN with amino acids is great, but it's just that protein and sugar. Some babies are on that for a full 24, 36 hours while their calcium is being depleted. So just things to think about and why you might be seeing it more often in the beginning. Again, to correct it for chloride, we want to, increase our chloride in our fluids. Mostly you're going to see NaCl, definitely some KCl, making adjustments to those TPNs. This is one of those times, on a ELBW baby where your total fluid that the baby is getting is 3 mils an hour, they can only add so much in there and still get enough free water and sugar and everything to the baby. That's what that whole TPN calculation that they're doing is. And so this idea of, do we do NaCl, do we do KCl, is a balancing act, and your dietitians are a huge part of it. Registered dietitians in the NICU have a huge role in what goes on in your TPN. So reach out to them. They are going to be a huge source of information for you. If your levels are high, you may need to get off of sodium fluids and onto acetate containing fluids. This is something to remember for your like TKO fluids that are in your UA and your UV. What are you running in there? Do we need to adjust those? Every little bit counts. In your EHR, whether you're an Epic or Cerner or whatever it might be, you can see in your eyes and nose how much they're getting of each fluid. This is why we should be tracking boluses, how many boluses a baby is getting. It affects all of that as far as your total fluids go and your sodium and chloride exposure. With your calcium, we do give calcium gluconate. Can't say I give it often. I think we know that it can be very tricky, both to vessels and to hearts, so we have to be careful. I haven't really seen high calcium that we felt so concerned we had to treat it. So that's something that I'm not an expert in. But obviously, if you have some in your TPN, you would want to be taking that. So those are your big 4 electrolytes that you as a bedside nurse would be drawing and paying attention to. The next big lab you're probably doing is your CBC. At the beginning, I mentioned that there are values out there, and this is one of those things that I made sure we put back on the slide. Values can vary based on gestational age, postnatal age, and condition. So yes, here's a great list of what's considered normal, but 35 in a 2-week-old 32-weeker is different than 35 in a 2-day-old 25-weeker. So they are not created equal. You have to take a look at the whole baby. This is why transfusion guidelines are so important, to really be able to say, like, is the baby having high oxygen requirements, or is the kid on room air, eating, waking up, sleeping in between their feeds, all of that, with a crit of 25? They're probably okay. What's their retic doing? They're probably okay. Was their CBC drawn 3 days ago and the crit was 35 and now it's 25? That's much more concerning to me than it was 35 yesterday and it's 34 today, but we've come down 10% in our oxygen. Let's see if we can go another day without a transfusion. So having some sort of transfusion guidelines that are going to address blood transfusion and platelet transfusion and anything else that you might be giving if the baby's in DIC is essential. Transfusions are not benign, so we need to make sure that we are paying attention to what's going on with the whole baby and not treating a value. So if the baby is anemic and the values are low, typically in the TOPS trial, right, there's this idea that in the first week of life in a symptomatic baby, if it gets below 35, we're probably transfusing. If the baby's not symptomatic, we might get to 30. If they're more than 2 weeks old, right, it's going to keep going from there. Guidelines are meant to guide us. It is not a set, oh my gosh, it's 29, we give the transfusion today. Oh, it's 30, it said it had to go below 30, we're not going to give the transfusion. No, they're guidelines meant to say, hey, let's take this whole picture into consideration. This is a great evidence-based project if you need one for your unit to implement transfusion guidelines. It goes for platelets, right? If the platelets are low, you're investigating for sepsis, NEC, DIC, typically less than 50,000. I've seen down to 30,000 for treatment on platelets. So something to just think about in regard to your transfusion guidelines. And then obviously if you're abnormal white blood cell count, you're looking for signs of sepsis. It can come from stress, so something to think about there. I did not put CRP on here because CRP labs depend often on what your lab does and how they report them. I have worked somewhere where 10 was considered high, and I worked somewhere where 100 was considered high. And I've read somewhere that 1.0 was considered high, all depending on where they put their decimal. And so putting it blatantly out here felt like too much. And CRP is non-specific and non-localizing. So a big thing if you're looking for an infection, you can watch a trend or look for a very, very high number, but those middle of the ground numbers often tell us nothing. So I didn't want to include it in here, but it is something to think about. Another lab that we do often is our glucose. Again, a normal range of 45 to 125. This is a big one where you are looking for trends. Remember, hyperglycemia, the really high blood sugar, is often an indicator of NEC. And if you're watching the sugar rise and rise, that's way more indicative of something than one random high one where it comes down. Obviously, you want to pay attention to that, but those are just things I'm thinking about. If your blood sugar is less than 45, you're going to treat it depending on the baby and their story. Are they feeding? Are they late preterm infant? What's going on with them? If they are small or they only have IV access or it's an infant of a diabetic mother, often you are going to treat a low blood sugar with a bolus of D10. So you're going to give D10, 2 mils per kilo over a pump over 5 to 10 minutes, recheck 20 to 30 minutes later in an IV situation. If they're PO feeding, we can sometimes give them extra food, change the calories, give an NG. There's going to be some variations depending on what's going on with the baby. But if you are giving an IV bolus, it is 2 mils per kilo. Bilirubin is another one that we draw often. We have an entire Teach Me Tuesday on hyperbilirubinemia, what our different total and direct billies mean, what you should be looking for. So I encourage you to go back and find that. Typically, I say if you have a bilirubin in the double digits, you should be paying attention. It is going to depend on how many hours, 2 days old the baby is, as well as if they are in a high risk zone. Preterm infants are always in a high risk zone. Their liver is not meant to process this bilirubin and their guts aren't eating. So in that case, if you're a 24 weeker and your level's 8, that's more concerning than if you're a 35 weeker and your level's 8. So there's no one great number, but in term late preterm infants, if you're in the double digits, you should be concerned, and anything over 20 should be making your heart freak out. So that's a general information for you, but go back and find the bilirubin Teach Me Tuesday. It's a great one about hyperbilirubinemia. Okay, those are the main labs we're going to cover. You may notice that one wasn't on there, and that's blood gases, and that's because if you're watching this, that is a preview to next week's Teach Me Tuesday, where we are going to dive all into blood gases, and that's why we didn't cover it here. We also are going to do a part 2 on some other nutrition type labs in July, so come back for that. But we as bedside nurses are doing this procedure where we have to draw blood on these babies. It is our job to make sure that they have good pain management. Sucrose is amazing. The first question you should actually ask yourself is, do we need this lab? Is it necessary? What's the least amount of blood that we need to get what we need out of it? Then you're going to give them the sucrose. Sucrose takes 2 minutes to kick in. Make sure you're giving it early. Give them a pacifier, whatever they need to help them through this. Even if your baby's NPO, they probably have a sucrose order. Sucrose. Swaddling. Swaddling doesn't have to mean every limb all tight, really ready to go. It can mean having a cover over their arms to help keep their arms contained during it. Keeping them kind of to middle. Having someone in there helping you kind of keep them to middle. The parents in there, as long as they can handle seeing blood. I always ask that before I poke, which we'll talk about on the next slide. But breastfeeding, giving them drops of breast milk, doing skin to skin, you can draw blood while a baby is skin to skin. Can you do it on every single baby every single time? Would I recommend doing a blood culture? Probably not. But a blood sugar, maybe just getting the baby's bilirubin because you have to have the lights off anyway. Let the mom hold during that. This is a great opportunity for some bonding during a painful procedure. So what should our families know? It's our job as a NICU nurse to explain, why am I doing this lab? What would I want to see in the lab? What would concern me? What might we anticipate for next orders? Maybe you're giving a sodium supplement and the parent's like, why are we giving this baby a sodium supplement? You can say, oh, well, when we draw the blood, Mondays and Thursdays, we see that the sodium is low. Here's a trend. Open up your EHR and show them. So there's great opportunities. Tell them why we're doing it, what kind of draw we're doing, how they can be there to be helpful, how we can support them, and of course, just reassuring them how important this is. I also just really encourage you to make sure if the parents are going to be there for the blood draw, especially if they want to help with containment, which is amazing. And I highly recommend make sure they can handle blood first, because I had a parent pass out on me once and I never wanted that to happen again, just from seeing a drop of blood on a blood sugar. So I can only imagine what would have happened if I had drawn a culture and a CBC. So just keep that in mind. So today we've gone through the major labs that we as NICU nurses draw: electrolytes, CBCs, blood sugar, bilirubin. More than anything, that's probably what you're doing and seeing on a day-to-day basis. As I mentioned, we will cover blood gases next week, so please tune in for that. Please remember to check what your lab's normals are, what your providers are looking for, and then anticipate what your next order may be. Be paying attention to when you might need more electrolytes drawn. If you had a low sodium and you started PO sodium, I wouldn't be drawing electrolytes the next day. Let's make sure we're giving the baby 72 or more hours to see a change in that number. And that's part of our job, is to really understand when would we anticipate seeing results. Thank you for joining me for this Teach Me Tuesday, and I will see you next week when we break down another neonatal topic.